Hello? Hello, am I audible?
கேக்குதுப்பா.
Okay, thank you. Screen 3 da?
Yeah, go on.
Okay. Good evening, everybody. Today we're going to see about Parkinson's disease. My objectives of today's session is going to be to know about the history of the illness, clinical features, Parkinson's mimics, etiopathogenesis, pathophysiology, genetics, and treatment. History of Parkinson's disease. It was first described by James Parkinson in 1817. In his words, it was characterized by involuntary tremulous motion with lessened muscular power, in parts not in action and even when supported, with a propensity to bend the trunk forward and to pass from a walking into a running pace, the senses and intellect being uninjured. He mainly concentrated on the tremulous motion and the lessened muscular power. He didn't talk much about rigidity. There is also this forward bending of the trunk was also explained by him. He's James Parkinson, and he's written an essay on the shaking palsy as early as 1817, first described by him. Something more about him is it is noteworthy that he was a general physician who captured the essence of this condition based on visual inspection of a mere handful of patients, several of whom he only observed and not even formally examined. He was well aware of how devastating the disease could be, where he said, the unhappy sufferer has considered it as an evil from the domination of which he had no prospect of escape. Coming to the clinical features, it is mainly of it's a tetrad of bradykinesia or hypokinesia, resting tremor, rigidity, and postural instability. Initial symptoms in patients with Parkinson's disease can be tremor in 70% cases, gait disturbance 11%, stiffness in 10%, slowness, muscle aches, loss of dexterity, handwriting disturbances, depression, nervousness, and other psychiatric disturbances and speech disturbances. Tremor is the most common symptom, as we can all see. These are the cardinal motor features, that is bradykinesia, resting tremor, rigidity, postural instability. Other motor features which include micrographia, masked faces, it's also called as hypomimia, reduced eye blinking, drooling, soft voice or hypophonia, dysphagia, and freezing. Non-motor features of Parkinson's include symptoms like anosmia, sensory disturbances like pain, mood disorders like depression, sleep disturbances, that is REM sleep behavior disorder, autonomic disturbances like orthostatic hypotension, GI disturbances, genitourinary disturbances, sexual dysfunction, cognitive impairment, and dementia. All these features are seen, that is, dementia is seen later in the duration of the disease. Coming to tremor, the most important symptom, it is mild and intermittent. It is evident only in one finger or one hand. That is, it indicates asymmetry. Approximately 4 per second pill rolling tremor of the thumb and fingers. It is typically present when the hand is motionless or at rest. That's why the name resting tremor. Complete relaxation, however, reduces or abolishes the tremor. So the term tremor in repose is a more accurate description. Volitional movement or voluntary movement dampens it momentarily, only to reappear. The rhythmic beat coincides with an alternating burst of activity in agonist and antagonist muscles in the EMG, and sometimes it can be palpable by the examiner, and hence it is also termed as alternating tremor. The arm, jaw, tongue, eyelids, and foot are, however, less involved. Even the least degree of tremor is felt during passive movement of a rigid part. So that's why we call it as a cogwheel phenomenon or Negro sign. This is an example of a pill rolling tremor. We can notice the right hand of this patient. Also, there is automatic movements in the left hand. There is a resting tremor. Patient's hand is at rest and there is movement. We can also notice this masked faces. There is less expression in her face. There is something called Bragg staging. Bragg staging is nothing but they have predicted the progression of the disease. That is Parkinson's disease. It has even before developing of the motor symptoms, there are certain other areas of the brain involvement where some symptoms are explained. Stage 1 is when the dorsal motor nucleus of vagus nerve is involved and anterior olfactory structures are involved, causing olfactory loss and autonomic dysfunction. Stage 2 is a lower raphe nucleus involvement, affecting impairment and affective impairment and sleep disturbance. Substantia nigra, when involved in the stage 3, motor clinical symptoms is seen. Stage 4, temporal mesocortex, where worsening of the motor symptoms and emotional disturbances like depression is seen. Temporal neocortex, sensory association in premotor areas, where worsening motor symptoms and cognitive changes like dementia is seen. So what we can see is only when the stage 3, that is when the disease is little progressed, only we're able to clinically pick up. So the recent research and everything is pointed towards picking up the disease in early stage. That is when there is even olfactory loss, autonomic dysfunction, or affective impairment or sleep disturbances in the elderly as age progresses. So this is the Bragg staging, which explains Parkinson's disease is progress. It's a progressive disease. Just a minute. Yeah. So Parkinson's disease is a progressive disease starting from olfactory loss, autonomic dysfunction, going to the motor symptoms and worsening of the motor symptoms. Again, it's the same explanation here. Clinical symptoms and time course of Parkinson's disease, that is here. Parkinson's disease can be diagnosed at this stage means the starting of the disease starts some around 20 years before. Patient might have mild symptoms or non-specific symptoms like constipation, REM sleep disorders. There can be hyposmia, that is smell disorders, depression can be seen. And when motor symptoms begin, we are able to diagnose the disease. And the motor symptom progresses, there is involvement of other higher mental functions, and there is dementia, and then ultimately patient can even go in for psychosis, and there can be frequent falls and etc. So in the excitement of some unusual circumstances, however, this patient is not going to have this all bradykinesia and everything, and the patient is going to be able to remarkably be free of the movement disorder. Like for example, if he sees fire, in spite of him being having bradykinesia and everything, he can escape fire. So this is called kinesis paradoxica. There is also inability to inhibit blinking in response to a tap over the bridge of the forehead, nose, or glabella. This is called Meyerson sign. But however, the primitive reflexes like grasp reflex and suck reflexes are not present unless dementia supervenes, and buccal and jaw jerks are rarely enhanced. Bradykinesia may also extend to eye movements. That is, there is delay in initiation of gaze to one side, slowing of conjugate movements, that is decreased maximal saccadic velocity, hypometric saccades, and breakdown of pursuit movements into small saccades. Drooling is a troublesome complaint. An excess flow of saliva has been assumed, but actually the problem is because of failure to swallow with normal frequency. This is also another video showing slowness of movement, reduced striding of arms is seen. So what all we can see in this video is there's slowness in initiation to start to walk. There is shortened strides and rapid small steps are seen. Decreased arm swinging is seen. Patient is turning as a whole, actually en blocked turning, and there's an expressionless face, that is our mask faces. All these are symptoms of Parkinson's disease. So the diagnosis of Parkinson's disease, we face two main difficulties. One is to distinguish typical Parkinson's disease from the main Parkinsonian syndromes, which also cause similar symptoms. And another one is to distinguish the Parkinson's tremor from other types of tremors like essential tremor. So Parkinson's disease is far more common than any other type of degenerative syndromes. A response of the main symptom to dopaminergic medication has been the most dependable feature for accurate diagnosis in several series. There is symptoms of tremors and other symptoms of Parkinson's when one notices, and there is a good response to levodopa. We make a diagnosis hence. So there is a criteria for Parkinson's diagnosis, that is MDS clinical diagnostic criteria. Here they say the minimal basic requirement for Parkinson's diagnosis is bradykinesia or hypokinesia plus either of rigidity or rest tremor. They are actually ignoring the postural instability here. So we can diagnose Parkinson's as either probable Parkinson's disease and possible Parkinson's disease. So probable Parkinson's disease is, the diagnosis is mainly based on three different headings. That is, absolute exclusion criteria should not be there. Red flag signs should also not be there to probably diagnose Parkinson's disease, and supportive criteria, at least one or two should be there. So for a clinically uh, established Parkinson's disease diagnosis, there should be absence of any of the absolute exclusion criteria, along with at least two supportive criteria and no red flag signs. For a diagnosis of probable Parkinson's disease, there should be absence of absolute exclusion criteria. One or two red flag signs can be there, but it should be equally balanced by the supportive criteria. Coming to them, absolute exclusion criteria include cerebellar signs, supranuclear gaze palsy, uh, diagnosis of either frontal temporal dementia, Parkinsonism restricted to the lower limbs only for more than 3 years, treatment with an anti-dopaminergic or with dopamine depletion agents, absence of response to levodopa should be there. I mean, should not be there. Sensory or cortical loss, no evidence for dopaminergic deficiency or functional imaging, other Parkinsonism inducing condition. That is nothing. When all these symptoms are there, we definitely cannot diagnose them as Parkinson's disease. Red flag signs means it can be there or it cannot be there. If it is there, we can put them under possible PD, I mean probable PD. Rapid deterioration of gait, absence of motor symptom progression over 5 years, early bulbar dysfunction, respiratory dysfunction, early severe autonomic failure, early recurrent falls due to misbalance, disproportionate antrocholis, absence of common non-motor features of disease during more than 5 years, pyramidal tract signs, bilateral symmetric presentation. Supportive criteria when present, we are going to tell them as Parkinson's disease. There is a clear and dramatic positive response to dopaminergic therapy, levodopa-induced dyskinesia, documentation of resting tremor of a limb, a positive diagnostic test of either olfactory loss or cardiac sympathetic denervation on scintigraphy. There is something called prodromal PD, that is diagnosing PD even before the patient develops motor symptoms. Prodromal PD refers to the stage wherein signs and symptoms of early neurodegeneration is present, but classical diagnosis of fully evolved motor Parkinson is not yet possible. This is under research at present. So coming to the next topic, that is Parkinson's mimics or differential diagnosis of Parkinson's disease. In comparison to Parkinson's disease, the atypical Parkinsonisms are characterized clinically by either early involvement of speech or gait, absence of rest tremor, lack of motor asymmetry, poor or no response to levodopa, and a more aggressive clinical course. We are going to see it in 4 different headings. That is Parkinson's disease, sporadic or genetic, dementia with Lewy bodies. Atypical Parkinson's, like multiple system atrophy, cerebellar type and Parkinson's type, PSP, progressive supranuclear palsy, corticobasilar syndrome, and frontotemporal dementia. Secondary Parkinson's can be like drug-induced, tumor, infection, vascular, normal pressure, hydrocephalus, trauma, liver failure, toxins can also cause them. Other rarer causes include neurodegenerative diseases like Wilson's, Huntington's, spinocerebellar ataxia, Fragile X ataxic tremor, Parkinsonism, prion diseases, and Alzheimer's, and dopa responsive dystonia. So let's first see the differential diagnosis. Multiple system atrophy. It mainly manifests as a combination of Parkinsonian, cerebellar, and autonomic features and can be divided as a predominant Parkinsonian MSA-P or a predominant cerebellar type MSA-C. So clinically, MSA is suspected when a patient presents with features of atypical Parkinsonism, along with cerebellar signs or prominent autonomic dysfunction, usually being orthostatic hypotension. Pathologically, MSA is characterized by degeneration of the SNC, striatum, cerebellum, and inferior olivary nuclei, along with characteristic glial cytoplasmic inclusions that stain positive for alpha-synuclein. Magnetic resonance imaging MRI can show, in case of a high signal change in the region of the external surface of putamen, a putaminal rim in MSAP, or a cerebellar and brainstem atrophy as in Hot-Cross-Bunn sign in MSAC. So the first picture shows Hot-Cross-Bunn sign, that is cerebellar atrophy and pontine atrophy. The middle one shows severe atrophy of pons and cerebellum, again relative reservation of midbrain volume, and the third picture shows sequence of bilateral putaminal hypointensity more marked than in the globus pallidus. So coming to the next differential, PSP, progressive supranuclear palsy. It is a form of atypical Parkinsonism that is characterized by slow ocular saccades, eyelid apraxia, and restricted vertical eye movements. So when there is earlier eye involvement, difficulty in downward gaze, all that is more pointing towards progressive supranuclear palsy. Patients frequently experience hyperextension of the neck with early gait disturbance and falls. In later stages, speech and swallowing difficulty and cognitive impairment may also be evident. There are again two different clinical forms. One is Parkinson form that can closely resemble Parkinson disease in early stages, including positive response to levodopa, and the more classic Richardson form, which is characterized by the features described above. So PSP is pathologically characterized by degeneration of the substantia nigra, striatum, subthalamic nucleus, midline thalamic nuclei, and pallidum, coupled with neurofibrillary tangles. That is, a tau protein formation is seen. Mutations in MAPT gene, which encodes for the tau protein, have been detected in some familial cases. Clinical, that is an MRI picture, we're going to see a hummingbird sign. This is because of the concavity at the upper border of midbrain, all degeneration of the midbrain. The third differential is corticobasal syndrome. It is the least common type of the three atypical Parkinsonisms. It presents with asymmetric dystonia, contractions, and clumsiness of one hand, coupled with cortical sensory disturbances, which manifest as apraxia, agnosia, focal limb myoclonus. There is an important phenomenon like alien limb phenomenon, where the limb assumes a position in space without the patient being aware of the position or recognizing that the limb belongs to him or her. Dementia may occur at any stage of the disease, and pathological findings include tau protein deposits even in this condition. So there can be an overlap between PSP and CBS pathologically and clinically. Coming to the corticobasal degeneration picture, there's going to be asymmetric atrophy of the cerebellum. So this shows cerebellar atrophy. It is mostly asymmetrical atrophy. So in this shows mostly a left-sided cerebellar atrophy where the patient has a useless right hand. So when are we going to suspect Parkinson's disease? That is Parkinson's plus syndrome is when these are going to be there. That is, a diagnosis of Parkinson's disease is made and treatment is started. The condition is poorly responding, and then we look for any of these signs and which points towards these differentials. So if there is falls as early or the first symptom is falls only, we'll mostly think of progressive supranuclear palsy because there'll be vertical gaze palsy, and so patient will easily start to fall in the earlier stages. Prominent orthostatic hypotension is going to be seen in MSA P subtype. Early dysarthria is going to be seen in the MSA C cerebellar type. If there is no tremor, we can think of all these Parkinson plus syndromes. Early hallucinations or dementia is going to be seen in Lewy body dementia, and alien limb phenomenon is going to be seen in corticobasal degeneration. So coming to the next differential, there is a secondary Parkinsonism. Secondary Parkinsonism occurs as a result of variety of primary conditions, which include drugs, infections, stroke, tumor, or exposure to toxins such as carbon monoxide or manganese. Clinical features reflect the region of the basal ganglia that has been damaged. Dopamine blocking agents such as neuroleptics are the most common cause of secondary Parkinsonism. That is, the drugs are the most common causes. Coming to the drugs, typical antipsychotics have known for a long time because for their extra pyramidal symptoms or Parkinsonism, like chlorpromazine, prochlorperazine, and atypical antipsychotics like risperidone, olanzapine can also cause these symptoms. Dopamine depleters, that is reserpine and tetrabenazine, can also cause these. Antiemetics, which we commonly use like metoclopramide, levosulpiride, can also result in Parkinson's like symptoms. And calcium channel blockers like flunarizine, cynarizine should also be kept in mind. These drugs are frequently causing Parkinson's. These drugs cause Parkinson's, but infrequently. Atypical antipsychotics like clozapine, quetiapine, mood stabilizers like lithium, antidepressants, SSRIs can also cause, and anti-epileptic drugs, valproic acid and phenytoin can also cause Parkinson's-like symptoms. Again, antiemetics like domperidone can also result in secondary Parkinsonism. So other rarer causes include dopa-responsive dystonia. It is a condition that results from mutation in the GTP cyclohydrolase 1 gene. This gene is involved in the formation of dopamine. So the onset of the disease is as early as 20 years. Others in other conditions like Wilson's disease, Huntington's disease, and certain forms of spinocerebellar ataxias, which has been clearly described in the last class. So all the majority of the forms of SCAs can cause Parkinson's, especially 1, 2, 3, and 6. Neurodegenerative disorders with brain iron accumulation, such as pantothenate kinase associated neurodegeneration, which is formerly known as Halliburton-Spatz disease. It's famous for its MRI finding being tiger eye, which that is because of hyperintense signals, that is necrosis, surrounded by the hyperintense ion accumulation in the middle aspects of globus pallidus. This is going to be resembling the eye of a tiger. It's famous for its MRA finding, which also can have symptoms of Parkinson's. So other rarer causes include encephalitis lethargica, which is they found it to be associated with encephalitis syndromes. I mean, encephalitis following encephalitis, patient may have this movement disorder, like they call it encephalitis lethargica. It is seen with Japanese B encephalitis, West Nile fever, and Eastern equine encephalitis. Other arteriopathic or arteriosclerotic form of Parkinson's disease are also known. When such a vascular cause is causing Parkinson's, we predominantly see a lower half Parkinsonism, in which shuffling gait, stickiness on turning, and falling are disproportionate to other features, and only the lower half of the body is involved, and there is symmetrical involvement as well. Another important differential is normal pressure hydrocephalus, including ataxia, dementia, and urinary incontinence as its features. Essential tremor is again a closed DD and most difficult to differentiate this tremor with a Parkinson's tremor. And there's also the famous punch drunk syndrome. It is seen in boxers, alcoholics. It's caused by repeated cerebral concussions. And well studied about this toxin, that is MPTP. It is a prodrug to neurotoxin MPP, which causes permanent symptoms of Parkinson's by destroying the dopaminergic neurons in the substantia nigra. Coming to the next thing, the features which suggest that is atypical or secondary causes, which we have seen a little earlier itself. Early speech and gait impairment is going to be seen in atypical Parkinsonism. Neuroleptic agents is causing drug-induced Parkinson's. Onset prior to 40 years, we can definitely think of genetic form of Parkinson's. Liver disease, when it's associated, we can think of Wilson's disease or other non-Wilsonian hepatolenticular degeneration. Early hallucination dementia is going to be seen in dementia with Lewy bodies. Diplopia, impaired down gaze. I mean, when eye involvement is there and impaired down gaze palsy is there, we are going to be thinking of PSP. Poor or no response to adequate trial of levodopa. Again, we have to think of atypical or secondary Parkinson's. So coming to etiopathogenesis, so most Parkinson's disease cases occur sporadically and they're of unknown causes. Only gene mutations have been known to be a direct relation with Parkinson's disease. Increased risk of developing PD in association with exposure to pesticides, rural living, farming, and drinking well water has been well studied. There are also certain protective factors included in Parkinson's, like caffeine drinking, smoking, intake of NSAIDs, and calcium channel blockers. So pathology, the most constant and pertinent finding in Parkinson's disease is a loss of pigmented cells in the substantia nigra and other pigmented nuclei in locus ceruleus. Locus ceruleus, dorsal motor nucleus of vagus. So the substantia nigra is visibly pale to the naked eye microscopically. The pigmented nuclei show a marked depletion of the cells and replacement gliosis. Many of the remaining cells of the pigmented nuclei contain eosinophilic cytoplasmic inclusions surrounded by a faint halo called Lewy bodies. Here we are seeing a degenerated cell with melanin deposition and also an eosinophilic deposition called Lewy body. This is the cut section showing substantia nigra, this black color pigmented region. In a Parkinson's patient, we are able to see an atrophy of the brainstem region and also absence of substantia nigra, a reduction in the pigment of SNC in Parkinson's disease. Here, this is a reduced number of cells in the substantia nigra in a Parkinson's disease. And this is the right side, this is the left side control in microscopy. So there is a reduced striatal uptake of a tracer in case of PET scan, which is most pronounced in the posterior putamen and tends to be asymmetric. Asymmetry is a very important feature in Parkinson's. So another imaging studies include dopamine transporter scans. Here we are able to see reduced uptake and a dot sign is seen in this dopamine transporter scans suggestive of Parkinson's. So coming to the gene mutations involved in Parkinson's, 5 to 15% of cases are familial in origin. Large size genome-wide association studies, which have identified 26 independent gene variants, which are single nucleotide polymorphisms as PD risk factors, including variants in the SNCA, LRRK2, MAPT, and GBA genes. as well as in HLA region on chromosome 6. It has been proposed that many cases of PD may be due to a double hit. That is, first there will be a genetic involvement, which is aggravated by any exposure from the environment, and then the patient is definitely develop Parkinson's disease. So some of the mutations what we see is alpha-synuclein mutations can be there, alpha-synuclein duplication can be there. All this is going to be resulting in accumulation or molecular crowding, profibrils formation. They form extra adducts. There is alpha-synuclein and dopamine adduct formation is there. There are also other genes involved in mitochondrial uh, electron transport chain as E1, E2, E3. There is also ubiquitin protein abnormality. Unwanted proteins are ubiquitinated, and then proteins are inappropriately degraded. All these result in Lewy body formation, and this Lewy body is hypothesized to cause neurotoxicity and the symptoms of PD. So the main genetics which we are going to be seeing, they are both autosomal dominant and recessive. So SCNA is widely studied. Alpha-synuclein gene is widely studied. Notation being PARK1 and PARK4. Age of onset is 40 years, and two main mutations are which promote oligomerization of the alpha-synuclein. I'm not going to all the details. Let us come to this LRRK2 gene. This is also well studied, especially in the Ashkenazi Jews, which cause abnormal protein synthesis called dardarin. It is also related to Gaucher's disease. So there's some newer hypothesis related to genetics and Parkinson's is that Lewy pathology was discovered to have developed in healthy embryonic dopaminergic neurons that had been implanted into the striatum of PD patients, suggesting that the abnormal protein had transferred from the affected cells to the healthy unaffected dopamine neurons. This is something what happens in a prion disease. So these findings have been proposed that the SNCA protein may be a prion, and the PD is that is a Parkinson's disease is a prion disease. This is all newer hypothesis and in research. Coming to the pathophysiology of what is exactly happening in Parkinson's disease, we have to understand two things. That is basal ganglia, direct pathway, indirect pathway, and what happens in Parkinson's disease. Structures. First we'll see the anatomy or the structures constituting the basal ganglia. This is a coronal section of the brain. Important structures which we are going to be seeing today is the putamen and caudate nucleus. This is the body of the caudate nucleus, and this is the tail of the caudate nucleus and putamen. Together, these three are called the striatum. Then comes the globus pallidus externa and interna, which is in pink in color marked here. And the other structures, this blue structure is the thalamus. The nucleus below the thalamus is the subthalamic nucleus, and the part the dark colored image here is the substantia nigra or the substance black. So these are the main structures or main nuclei constituting the basal ganglia, except for the thalamus, of course. So before going to the details, we'll just see that is when there is a synapse, when the neurotransmitter is GABA, it's going to be an inhibitory effect. And when the neurotransmitter is going to be glutamate, it is going to cause a excitatory effect in the postsynaptic synapse. So we are going to be seeing what happens physiologically, what happens in basal ganglia. So for that, let's first know about the ground rules, what happens in the brain. Thalamus is such a structure which always is in an excitatory state, stimulating the motor cortex, causing movements. So this thalamus is controlled by the globus pallidus interna, which acts as a leash. That is, this keeps the thalamus in check with inhibitory signals, which prevents the stimulation of the motor cortex. Substantia nigra and subthalamic nucleus, these two are mainly important for the fine-tuning of the movements. So what is direct pathway and indirect pathway in basal ganglia? Direct pathway is initiated when we need a movement to happen, and indirect pathway is initiated when we do not need a movement to happen. That is, movement happens in direct pathway, movement does not happen in indirect pathway. This is a simplified network of all the structures involved during direct and indirect pathway. So we have the motor cortex here, which is mainly stimulated when we think we need to do an action. This the motor cortex needs to be stimulated, and which in turn stimulates the muscles, and we get an action. So how this motor cortex is stimulated and how the basal ganglia plays an important role in fine-tuning the actions of the muscles. we'll see in both direct and indirect pathway. So coming to the direct pathway, so the first is when the motor cortex thinks it needs to make a movement, it is stimulated. It gives an excitatory stimulus to the striatum with the help of the glutamate neurotransmitter. Striatum is excited. This excited striatum is actually making a synapse with an inhibitory pathway. This inhibitory pathway is going into the globus pallidus. So this is going to the globus pallidus interna. Globus pallidus that is, the striatum is excited just only to inhibit the globus pallidus interna. This globus pallidus interna in turn is going and inhibiting the thalamus. So thalamus once when inhibited, there is not going to be a there is just a minute. So cerebral cortex thinks of giving a thinks of making a motor movement. It gives an excitatory message to the striatum. This there is a synapse with the inhibitory neuron in the striatum. So from striatum there is more inhibition into the globus pallidus interna. So this that is the globus pallidus interna is inhibited. That is, there is less activation of the thalamus from the globus pallidus interna. So when there is less inhibition of thalamus, the motor cortex is activated, and this causes the stimulation of the muscles, and the muscles start to move. So I'll just repeat it again. The motor cortex initiates the movement. It stimulates the striatum. It thinks that it has to move, so it stimulates the striatum. These neurons, the neurons in the striatum, they have a connection with the globus pallidus through an inhibitory pathway. So once when striatum is excited, actually it is inhibiting the globus pallidus interna. This globus pallidus interna, as it is inhibited, it further loses its inhibition to the thalamus. So normally globus pallidus interna will cause inhibition to the thalamus. When striatum is activated, striatum is inhibiting this inhibition to thalamus. So thalamus is less inhibited and the motor cortex starts to move. This is one pathway which happens. Another one, there is another connection between substantia nigra and subthalamic nucleus. What happens here is substantia nigra has dopaminergic neurons which go into the striatum, and acting on D1 receptors, it further inhibits the inhibitory neurons of the globus pallidus. So by this pathway, substantia nigra through the D1 receptors further inhibits the globus pallidus interna, which again reduces the inhibition to thalamus. So it further activates the motor cortex. So direct pathway is wholly about initiation of movements or making the movements happen. There's another fine tuning within here between the substantia nigra and the subthalamic nucleus. So what happens here is usually subthalamic nucleus gives in excitatory neurotransmitters messages to substantia nigra. And the substantia nigra, however, keeps this excitation in check by giving certain other inhibitory signals to the subthalamic nucleus. So all this ultimately, what we're trying to tell is in direct pathway, there is less inhibition of thalamus by the globus pallidus. So thalamus is again activated more, which sends signals to the motor cortex for the muscles to move. Coming to the indirect pathway, the main aim of indirect pathway is to not make the movements happen. What they've compared here is the thalamus to a very active puppy, which is persistently activating the motor cortex. So what happens here is we have to increase this inhibition. I mean, this thalamus is kept in check by the globus pallidus interna. So our aim in indirect pathway is to more stimulate the globus pallidus interna, so that the thalamus is not stimulated and the motor cortex is not stimulated. So here what happens is motor cortex. I'm sorry. Yeah, motor cortex is not is trying to not make the movement, so that is stimulating the striatum. In here, the striatum, it sends inhibitory neurons to the globus pallidus externa. This globus pallidus externa activity is turned down. So what happens is less stimulation to the subthalamic nucleus, and via the subthalamic nucleus there is less stimulation of the globus pallidus interna. So when there is less stimulation, there is going to be overactivation of the thalamus, and this and this when there's overactivation of the globus pallidus interna, the thalamus is again further inhibited, and then there is no movement by the motor cortex. So ultimately, what we need to remember is mainly this, that in direct pathway, movements are happening by uh, inhibiting the inhibitory stimulus of the globus pallidus interna to the thalamus, and hence the motor cortex is activated. While in indirect pathway, the action is inhibited by activating the globus pallidus interna. Here, there is also another indirect pathway by which movements are increased. Here, what happens is, there is connection between the subthalamic nucleus and substantia nigra. There is a excitatory message which goes into the substantia nigra. This substantia nigra sends D2 receptors, that is dopamine, to the D2 receptors in striatum. Here, there's a synapse with an excitatory neurons in the striatum, which causes less inhibition of the globus pallidus externa. So there is less activation via the subthalamic nucleus to the globus pallidus interna, and there is a increase in motor cortex stimulation and increase in action. That is, even in indirect pathway, there is some stimulation from the substantia nigra, which also causes increase in movement. So what we need to understand from this is that substantia nigra in both direct and indirect pathway is ultimately resulting in some amount of movement in the body. So in case of Parkinson's disease, there's mainly a problem between the substantia that is the nigrostriatal pathway. There is a depletion of neurons in the nigrostriatal pathway, and also formation of Lewy bodies. So what happens normally is, in direct pathway, the thalamus is more active and there is more movement. In indirect pathway, the thalamus is less active and there is decreased movement. But when the dopaminergic neurons are reduced, the substantia nigra and the nigrostriatal pathway is affected. Because of this affection, finally, what we have is there is slowing or loss of movement. So coming to the treatment, mainly we have levodopa, carbidopa, dopamine agonists, MAO-B inhibitors, and COMT inhibitors, and other treatment what we will be seeing. Main levodopa. Levodopa is converted into dopamine with the help of dopa decarboxylase. Dopa decarboxylase is prevented by carbidopa. This is to prevent the conversion to dopamine outside the brain, and to avoid the dopaminergic side effects outside the brain, where we do not want the dopaminergic actions. So since its introduction in the late 90s, it has been the mainstay of therapy for Parkinson's disease. The theoretical basis for the use of this compound, it rests on the observation that the striatal dopamine is depleted in patients with Parkinson's disease, but the remaining deceased nigral cells are still capable of producing some amount of dopamine by taking up its precursor L-dopa. So levodopa is routinely administered in combination with the peripheral decarboxylase inhibitor, which we already saw, carbidopa. This is to prevent the dopaminergic side effects like nausea, vomiting, and orthostatic hypotension, which happens outside the blood-brain barrier. There is also a recent inhaled form of levodopa. It is rapidly and reliably absorbed. This is mainstay rescue therapy for individuals in off episodes. So dopaminergic side effects are transient and can be generally avoided by starting with a low dose and titrating the dosage. They can be treated with additional doses of peripheral decarboxylase inhibitors like carbidopa, or administering with food, or adding a peripheral dopamine blocking agent like domperidone. Levodopa-induced motor complications causes fluctuations in the motor response, that is on episodes and off episodes. And involuntary movements known as dyskinesias can also be seen, which typically complicates the on periods. This is with continued treatment, however, duration of benefit following an individual dose becomes progressively shorter until it approaches the half-life of 60 to 90 minutes. That is, initially patient might be hello. Yeah, initially patient might be having a good response, but however, as days pass by, the response wears off, and then the response stays only till the half-life of the drug. So the loss of benefit is this also known as the wearing off effect. In more severe cases, The response to a given dose may be variable, with patients potentially experiencing a delay in turning on, that is delayed on, or no response at all. There is no on. What we have to know is levodopa can be a good drug in the initial stages of Parkinson's, but with time, its effects are reduced, and this is what we call it as wearing off effect. So, surgical lesions or high frequency stimulation of targeted at the globus pallidus interna or subthalamic nucleus is the what we can do in case of dyskinesias in levodopa. So, hello.
Audible.
Okay,
Priyanka. Carry on.
okay, sir. Uh, Current information suggests that altered neuronal firing patterns and motor complications develop in response to non-physiological levodopa replacement. So, what they have found out that because we are giving levodopa in tedious doses, there is no persistent levodopa levels in the system. So, what they have found out that continuous intra-intestinal infusion of levodopa is associated with a significant improvement of the off time and the on time without dyskinesia. So there can be other disadvantages of levodopa can be behavioral complication, which is also called as punding. Coming to the next drug, there is dopamine agonist. Initial dopamine agonists were ergot derivatives, bromocriptine, pergolide, or cabergoline. It is associated with potentially serious ergot-related side effects like cardiac valvular damage and pulmonary fibrosis. Second generation of non-ergot dopamine agonists are pramipexole, ropinirole, and rotigotin. They are less potent than levodopa to induce dyskinesias and possibly because they have a relatively longer half-life. Uh, Side effects associated with chronic use
Priyanka,
sir.
Priyanka.
Solung, sir.
Okay. My Ravindran, can you please mute your mic so that it will be easy for others? Okay, start பண்ணுங்க. Ravindran mic தான் மட்டும்.
Okay, okay, sir.
மியூட் ரவீந்திரநாத்மா, அதனால எக்ஸ்ட்ரா சவுண்ட்ஸ் வருது.
Okay, okay. I think I'll continue just a minute. Yeah. Yeah. So acute side effects are primarily dopaminergic and include nausea, vomiting, and orthostatic hypotension. Side effects associated with chronic use include hallucination and cognitive impairment. Dopamine agonist can also be associated with impulse control disorders, including pathological gambling, hypersexuality, and compulsive eating and shopping disorders. Sedation with sudden unintended episodes of falling asleep have been reported using dopamine agonists. Coming to the next group, MAO-B inhibitors. Inhibitors of monoamine oxidase type B, they block the central dopamine metabolism and increase the synaptic concentrations of the neurotransmitter. What happens is, examples of the drugs is seligelin and rasagelin. They are relatively selective suicide inhibitors of the MAO-B isoform of the enzyme. They are not neuroprotective as they were thought previously. The studies have not proven so. The main advantage is that it reduces the off time when you use as an adjunct to the levodopa. So inhibition of MAO-A, that is this A isoform of the enzyme, can cause effect called cheese effect when if it is precipitated by foods rich in tyramine such as cheese, aged meat, and red wine. Theoretical risks of serotonin reaction when taken along with an SSRI is also known, but it is very infrequent. A newer drug of this group is safinamide, available in 100 mg. It has recently been approved as an adjunct to levodopa in advanced Parkinson's disease with motor fluctuations. The drug also acts to block activated sodium channels and inhibit glutamate release. So it is also used as a possible anti-dyskinetic agent. Next group is COMT inhibitors. Inhibitors of COMT increase the elimination half-life of levodopa and hence enhance its brain availability. So combining levodopa with COMT inhibitor reduces the off time and prolongs the on time in fluctuating patients. Examples of this include tolcapone, entacapone, and opicapone. Opicapone is a recent long-acting drug. And tolcapone is associated with fatal hepatotoxicity. It has been proposed that initiating levodopa in combination with a COMT inhibitor to enhance its elimination half-life could provide more continuous levodopa delivery, and so less motor complications are seen. For now, the main value of COMT inhibitors continues to be in patients who experience this motor fluctuations. Other medical treatment which we use are centrally acting anticholinergic drugs like trihexyphenidyl and benztropine. Their major clinical effect is on reducing the tremor. Their use is limited particularly in the elderly due to their propensity to induce a variety of side effects including urinary dysfunction, glaucoma, and cognitive impairment. Other important drug used is amantadine, which is which is an antiviral drug. It is appreciated to have an anti-Parkinson effect because of the NMDA receptor antagonism. The anticonvulsant zonisamide with unknown mechanism has also been used to show actions in Parkinson's disease. Neuroprotective therapy is actually under research, and it's an unmet therapeutic need. That is, all these are only symptomatic. We are only managing the Parkinson's disease symptom, and we are not completely curing the disease. So drugs which we are commonly use are levodopa carbidopa. It is available in 1:4 combination, or sometimes in 1:10 combination also it's available. Other dopaminergic agonists like ropinirole and pramipexole, glutamate agonist, that is NMDA agonist, antagonist amantadine, and anticholinergics like trihexyphenidyl, benztropine are used. COMT inhibitors, entacapone is used. It is also in combination with levodopa available. MAO-B inhibitors, rasagiline, saligiline is also widely used. So coming to the next modality, surgical treatment. Initially, what they did was they were making brain lesions by placing them in the motor cortex, and which they also found improvement in the tremor, but were associated with motor deficits, and this approach was abandoned because of the abundant side effects associated with it. Initially, they were trying to make lesions in the postroventral portion of the globus pallidus interna, and improved rigidity and bradykinesia also, as well as tremor. Pallidotomy, that is the lesion in the globus pallidus, was also associated with marked improvement in the contralateral dyskinesia. When there is a brain lesion of subthalamic nucleus was done, it was associated with anti-Parkinsonian benefit, but there was concerns about hemipallismus, and the procedure is not, all these procedures are only of historic importance and nothing is performed now. What we do now is called deep brain stimulation. This is by placing an electrode by surgically placing a lead electrode and stimulating this electrode continuously by placing a pulse generator just below the clavicle. So what we do is an electrode is placed into the target area and connected to a stimulator is inserted subcutaneously. It simulates the effect of a lesion without actually making a lesion in the brain. So DBS for Parkinson's disease targets the subthalamic nucleus of the globus pallidus interna. The procedure is primarily indicated for patients who suffer disability resulting from severe tremor or levodopa-induced motor complications that cannot be satisfactorily controlled with other drugs. So MRI-guided ultrasound is a recent developing area of treatment, is being used as a means of damaging critical target lesions such as the globus pallidus interna in PD patients with motor complications in a non-invasive manner that avoids the risk of surgery. Other experimental therapies which are in study are cell-based therapies such as transplantation of fetal nigral dopamine cells or dopamine neurons derived from stem cells. Gene therapies, trophic factors are also being used. All these, and there is also gene-specific target therapies which are in trial. Glial-derived neurotrophic factor (GDNF) and neuroturin have attracted particular attention in possible therapies for Parkinson's disease. Gene therapy is nothing but involving, placing a part of DNA for therapeutic protein into a viral vector, and then taken up and incorporated into the genome of the host cell, and then synthesize a proper protein, and which is this proper protein is released continuously to prevent the loss of dopaminergic neurons. So other management of non-motor, non-dopaminergic features include anxiety, panic attacks, depression, pain, sweating, sensory problems, freezing, and constipation. All these needs to be addressed. Antidepressants should not be withheld in spite of risk for serotonin syndrome, maybe we can avoid salicylic, but other antidepressants, if needed, should be used, and salicylic should be avoided. Anxiety is also a common problem. For this, we can give short-acting benzodiazepines. Psychosis can also be a problem in PD in later diseases, and it is often a harbinger of dementia. It can also be treated with the clozapine or other antipsychotics. Non-pharmacological therapy include using canes and walkers, yeah, having some sensory cues to overcome freezing. When the patient if a patient completely freezes, he's not able to move, we can try and ask him to sing a song or something which gives him a different stimulus, and then he can try to move. Speech therapy is used, exercise can be advised, yoga therapy can be advised, and most importantly, care for the patient is more important. Current management of Parkinson's disease, again, it's tailored to each individual. There is no single treatment approach that is universally accepted for for all individuals. So coming to levodopas and its varying of effect on levodopa is another, I'm just emphasizing the point again. In early Parkinson's disease, the effect of levodopa is going to be very beneficial. It is not going to reach dyskinesia threshold, and the response is going to last for a longer time. When in moderate PD, that is, as the days pass by, duration pass by, what happens is the dyskinesia threshold is met and there is unwanted motor symptoms developing, and also the duration of lack of symptoms is also becoming less. And in case of advanced PD, there is dyskinesia threshold is overcome, and then a lot of motor related side effects are seen in levodopa. So just coming to a treatment algorithm for Parkinson's disease. When we diagnose the Parkinson's disease, we have to give the patient some non-pharmacological intervention like exercise or some other supportive management. Pharmacological intervention, when we need, we usually start with neuroprotective agents like rasajalin, but it is not very much proven. When there is a prominent functional disability, motor symptoms are disturbing, we have to start the patient on levodopa. Levodopa is better started with the combination therapy, levodopa plus carbidopa, or levodopa and the dopamine agonist, COMT inhibitor, or MAO-B inhibitors. Apart from that, we can also give dopamine agonist or MAO-B inhibitor. We can start the patient with that, and then you can start the patient on levodopa. It again depends from physician to physician. If in spite of all the treatment, if the patient is still having motor symptoms, or if the dosage of levodopa has crossed its dyskinesia threshold, patient will have dyskinesias, and for this, we can go for surgery or a deep brain stimulation. Thank you. My reference is studies. Thank you for patient listening.
பிரியங்கா
Sir.
பிரியங்கா லீவோடோப்பா பத்தி முதல்ல சொன்னது மட்டும் திருப்பி போடுறீங்களா? நான் இடையில ஸ்கிப் பண்ணிட்டேன்.
Okay.
அந்த டோஸ் பத்தி ஏதாவது பேசுனீங்களா? லீவோடோப்பா வித் கார்பிடோப்பா காம்பினேஷன், why it is needed பத்திலாம்.
Yes, sir.
ட்ரைஎக்சிஃபென்டில் பத்தி ஏதாவது பேசுனீங்களா?
Yes, sir.
அந்த 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 few slides மட்டும்.
Okay, sir. So levodopa is mainly used as a dopamine precursor. It acts in the brain. Peripheral action is prevented by using carbidopa to avoid the dopaminergic side effects which happen in the periphery. Carbidopa is a dopa decarboxylase inhibitor.
What are all the dopaminergic side effects?
Dopaminergic side effects like nausea, vomiting, orthostatic hypotension can be seen, sir.
Dopamine causing hypotension.
Yes, sir. Or அதான் அதோட சைடு எஃபெக்ட்ஸ்னு கொடுத்திருந்தாங்க சார். levodopa is routinely
ஆக்சுவலா
sir.
டாக்கிகார்டியா வரணுங்க.
Okay, sir.
அந்த டாக்கிகார்டியானால ஹைப்போடென்ஷன் வரும்.
Okay, sir. It is routinely administered in combination with peripheral decarboxylase inhibitor to prevent its peripheral metabolism to dopamine and development of nausea, vomiting, and orthostatic hypotension due to activation of dopamine receptors in the area postrema that are not protected by blood-brain barrier. And
Starting dose.
Sir,
Starting dose.
sir, 100 mg levodopa with 10 mg carbidopa 110 mg ல ஸ்டார்ட் பண்ணுவோம் சார்.
Hmm.
It can the maximum we can increase the dose up to 50 and 250 mg every 3 hourly can be given, sir.
What about triaxiphendine?
Sir, it is an anticholinergic drug. It's mainly given in case of tremors, sir. Starting dose is 0.5 mg BD. Up to 2 mg TDS can be given. It is usually avoided in younger age individuals to avoid its side effects like urinary distension, incontinence, and other side effects, sir.
Thank you, Priyanka.
Okay, sir.
Any questions? Imtiaz?
Sir, no, sir.
Anyone else? ஓ 69 ஸ்லேட் பர்சன்ட் பண்ணீங்களாங்க?
சரி 80 சார்.
80? ஓ சூப்பர்ங்க. நான் தான் கொஞ்சம் லேட் ஆகுது, சாரிங்க.
இல்ல
சார். Any questions from first year, second years? Final years யார் யார் இருக்கா? எல்லாருமே இருக்கீங்க. ஸ்ரீநிதி மட்டும் காணோம். பிரிஜேஷ்?
Sir, no questions, sir. No questions.
Brijesh is clear. எந்த டவுட்டும் இல்ல.
Sir, அப்படி இல்ல sir.
Thank you, Priyanka. Anything else? Anyone want to add something? If there are no questions, we can finish this. Thank you.
Okay, sir. Thank you, sir.
Good night.
Night, sir.